Welcome to the ASGE Video Tip of the Week. I'm Dr. Chris Thompson from Brigham and Women's Hospital, and I'm here with one of our second-year GI fellows, Dr. Sai Pichamon Jirapinyo. And she's going to tell us about a case of a patient with Roux-en-Y gastric bypass and chronic abdominal pain.
Thank you, Dr. Thompson. Here we have a 38-year-old female with a history of Roux-en-Y gastric bypass 7 years ago. She came in with a history of chronic left upper quadrant pain for the past 3 years. Previous workup, including a CT scan and an EGD, were negative. The following procedure has been performed. Here, we're passing through the gastroesophageal junction and entering into the pouch. It's important to retroflex within the pouch to look for a gastrogastric fistula or other abnormalities. We then pass through the gastrojejunal anastomosis before examining the blind limb. Close attention should be paid to the posterior jejunal aspect of the gastrojejunal anastomosis, as this is the most common site of marginal ulceration. The endoscope is then passed down the Roux limb, which is typically 100 to 150 cm in length. However, there's no consensus on ideal length. Here we'll see the jejunal anastomosis. This is an example of an end-to-side anastomosis where both the common channel and the biliopancreatic limb are easily accessed. Unfortunately, it makes it harder to predict which is which limb. After exploring the limb for over 100 cm, it becomes obvious this is most likely the common channel. The scope is withdrawn to the jejunal anastomosis and the adjacent limb is entered. We then enter the biliopancreatic limb, which usually has bile in it. Here's the distal side of the pylorus. Entering through the pylorus, we then reach the remnant stomach. We see gastric erythema and erythematous streaks suggestive of gastritis. We also see bilious fluids, which are aspirated. Biopsies are then performed. Retroflexion within the remnant stomach shows no abnormalities. On scope withdrawal, we then perform tattoo injection in order to identify the limb in case a repeat procedure is needed. A pH test using a test strip shows that the aspirated fluid from the remnant stomach is basic, with a pH of 8.
The biopsies of the remnant stomach reveal chronic active gastritis. As shown here, increased lymphocytes and plasma cells are seen in the lamina propria, suggestive of chronic gastritis. Scant neutrophils are also observed in the lamina propria and glandular epithelium, which indicates the mild active component. Additionally, mucosal edema, mucin depletion, and branching and corkscrewing of the pits are present, which are usually associated with chemical gastropathy, which can be caused by chronic bile reflux or long-term NSAID use. The H. pylori stain is negative. Total bilirubin level of the aspirated fluid is 8.5, suggestive that the chemical gastropathy is most likely caused by bile reflux.
The differential diagnosis for abdominal pain in the Roux-en-Y gastric bypass patient is relatively broad, and unfortunately, many patients have an unremarkable workup. Up to 80% of patients that have had a thorough and negative evaluation will have pooled bile and gastric erythema consistent with remnant gastropathy on a direct endoscopic evaluation of the remnant stomach. Evaluation of the remnant stomach can be challenging in gastric bypass patients. Pediatric colonoscopes and enteroscopes have been used with variable success. However, device-assisted endoscopy tends to be more successful, with rates as high as 80% in experienced centers. Additionally, HIDA scans can be suggestive of bile acid gastropathy if pooling of bile is seen in the remnant stomach. Bile reflux gastropathy is a type of chemical gastropathy similar to NSAID-induced gastropathy, and the degree of toxicity is influenced by a number of variables, including the concentration of bile salts in the gastric juice, type of bile salts present, gastric pH, and presence of pancreatic enzymes. Our preferred treatment for remnant gastropathy is ursodeoxycholic acid. This is a non-toxic, naturally occurring bile acid that is thought to shift the balance of bile acids and allow for mucosal healing. Our typical starting dose is 500 milligrams twice daily, and we'll increase this to 1,000 milligrams twice daily if there's only a partial or no response at 3 months. Patients are always instructed to crush the medication to ensure adequate absorption. It is important to remember that the remnant stomach in Roux-en-Y gastric bypass patients no longer comes in contact with ingested food or medications. Accordingly, medications that are intended to coat the stomach as part of their mechanism of action, such as sulforphate or cholestyramine, are less effective. Small case series suggest that 80% of patients with a diagnosis of remnant gastropathy that are treated with ursodeoxycholic acid and a proton pump inhibitor will experience significant or complete resolution of abdominal pain. This was true whether the diagnosis was made via direct endoscopic evaluation or HIDA scan. This response was also considerably better than those patients treated with a proton pump inhibitor alone.
So usually which scope would you use for this procedure, Dr. Thompson?
In this particular case, we used an ultra-thin pediatric colonoscope. And certainly if you know that that roux limb is rather short, you can reach the remnant stomach with a pediatric colonoscope. I would not use an adult colonoscope. I would worry that might be too traumatic. If you don't know the length of that roux limb, or you know it's longer, then you will need device-assisted enteroscopy. So a single balloon endoscope, a double balloon endoscope, or a spiral over tube are typically required.
So in addition to ursodiol, would you recommend her continuing her PPI?
Yes, so we do recommend patients continue their PPI. The vast majority of patients do come to us already on PPIs when they're having chronic abdominal pain. There's not necessarily great evidence for that, but that has been our practice.
All right, thank you very much.
Thank you.